members. Today's webinar is a part of NEMSI's Clinical Judgement webinar series titled Deciding What to Teach, presented by Jeffrey Anderson, Paramedic Program Director at Bossier Parish Community College. I'm going to pass it over now to our presenter. Jeff, thank you so much for being here with us again today to share your knowledge and experience with us, and we look forward to the presentation.
Thank you. So just a little bit of background about this. I'm part of the group that's been doing the clinical judgment workshops. We did one at the NAMC Works Symposium last couple months ago, and we'll be doing another one at the next symposium, plus a couple more in between. So there's four of us, plus some registry people and some NIMS people that are working on how to teach and augment our instruction for clinical judgment. And I chose this topic for the first webinar that I'm doing because I think, knowledge and curriculum are very important in clinical judgment. It's hard to think critically and apply things you don't know. And so that's where we as educators really have a responsibility, is to create a program, create the curriculum for our programs that will facilitate good, solid clinical judgment. And so one of the things I wanted to do to start is give you my take-home points about what I want to cover today. So the first thing I want to talk about is how we own the curriculum as the program and as the educators. The second thing I want to talk about is a little bit about curriculum design, which kind of starts with beginning with the end in mind, to steal a phrase from Dr. Stephen Covey. And then I want to talk a little bit about some different kinds of knowledge we need to think about as we're developing our materials. And then lastly, we're going to talk a little bit about using taxonomies to help create our curriculum and our assessments. So the first topic I wanted to talk a little bit about is how we own the curriculum. I started teaching back in the late 90s when we were still under the Department of Transportation curriculum. So in those days, we were given a curriculum by the DOT that we were to follow. Depending on how picky you wanted to be, we could look at it as a floor or a ceiling or as both. And we had lots of arguments about what should or shouldn't be in the curriculum. And because it was a document produced by the feds, obviously it didn't change very fast. And other healthcare disciplines had transitioned away from having prescriptive curricula like that before us. And with the advent of the education standards, we moved into that realm. But I think a lot of us didn't really realize what that meant at the time. I know I didn't, how much responsibility the program was going to have for creating a curriculum. So first off, let's define what a curriculum is. Now, Webster says that curriculum is either the courses offered by an educational institution or a set of courses constituting an area of specialization. So to take that definition and apply it specifically to our world, my argument is that our curriculum for an EMS program is what we teach, so the content, when we teach it, the sequencing, how we teach it, the instructional methods we use, and the other things. And then lastly, how we assess what has been taught, because it doesn't really do a whole lot of good to teach people things and then not measure whether they've actually learned them or not, because some of our concepts are complicated and different people are going to struggle with different things. So we need to be assessing them frequently, because that assessment helps them learn and it helps us understand where we need to pivot and revisit and things like that. So what an EMS program curriculum is not is the National Registry curriculum. You see this come up in discussions on social media and in other places where, well, what's the NREMT curriculum? What's the NREMT drug list? What are the NREMT standards for whatever question we want to talk about? And the reality is there's no such thing. The NREMT doesn't dictate curriculum. They don't dictate standards. They don't do any of that. They're a testing agency. And so obviously we would want to make sure that our curriculum prepares students for their test. We shouldn't base our curriculum just on what's on the test, and we shouldn't look to them for guidance about these things. That's going to come from other places. So that's a commonly misunderstood thing amongst providers, amongst employers, even some educators. But I think, employers really, I hear this a lot. So it's something that we've not, I guess, probably done the best job communicating as a profession. But so, like I said, we're not looking to the National Registry for any of this. They have their plate full. We don't have the DOT curriculum anymore. That's another big thing I hear people still to this day mention, is the DOT curriculum. Well, those are gone. The last one for paramedic, I believe, was introduced in '99. Last one from EMT, I think, was 94. And I could be wrong on those dates, but we don't get those things from the DOT anymore. We get the National EMS Education Standards that we would base our curriculum on. We got the instructional guides in the first round of all of this, when the first edition of the National EMS Education Standards were released. Those guides were meant to help us implement the standards. They were meant to help textbook writers know what to cover and whatnot, but they were never meant to replace the national standard curriculum. They were meant as a guide, and they weren't kept up to date completely because of that. And so, like I said, we don't have a DOT curriculum anymore. Our textbooks are not curriculum. Sometimes we get a bunch of resources from our textbooks, and they're great resources. Most of them require some sort of modification or whatever to make them work inside our programs. But a textbook itself is not the curriculum. The materials provided with the textbook are not the curriculum. All of those things need to be generated by the program. Now, obviously, we use textbooks to deliver our curriculum. That's very important. I know there's a debate going on in education about whether we still need textbooks or not. I'm still on the camp of I want my students to have a textbook, but there are limitations to those. And one of those big limitations is they're not the curriculum. They're not meant to dictate how we teach, the order we teach, or anything like that. We encountered this in our program with the new edition of our paramedic textbook. The sequencing of the chapters is different than the way that we've presented our courses historically. And so we've made a few adjustments here and there to accommodate for that. But all of that was minor stuff. We already had the curriculum in place that we were using the textbook to deliver. The National EMS Education Standards are not a curriculum. They are a document that is used to build our curriculum in our programs, to write our syllabi, write the objectives, all of that. They're a great place to start when it comes to the curriculum of our program, but they really are a floor more than anything else. They're a guide that helps us understand what the minimum should be covered. And they do have an excellent discussion about the differences between the different provider levels and what should be in our curriculum, but they're not the curriculums themselves. This is taken from the EMS Education Standards. The document itself, I commend it all of you to read. It's an excellent document on building curriculum and how to structure an EMS education program. There's just so much good information in there. And one of the things I wanted to talk about is what we should use to influence our curriculum. If it's up to us as the program to create the curriculum, then where do we get this information from? What do we use to guide us? We're not expecting you to just create this out of whole cloth. There's guidelines out there, and there's things to help us. So I would start at the federal level. None of this comes from the federal government or for the registry, but it comes from by mandate. But these are things that our federal agency has proposed to us, and most of our states have adopted them. So you've got the EMS Education for the Future, the EMS core content, which is like the list of things that we're supposed to know, the scope of practice model, the ed standards, the education agenda for 2050, and then other stakeholder interests. So those are the federal documents. I would start with the ed standards. Obviously, that's going to be the place we start when we're looking for what to cover, and then we could refer to other things as well. If you're in paramedic education, you've got your accrediting body. So we would consider COAMPS and CAHEP in this. One of the things that factors into our curriculum is the student minimum competencies. So as we design the curriculum for our program, we need to make sure we meet all of those student minimum competencies that have come from COA. If you're an advanced EMT program, you've got the same document from NASEMSO, the student minimum competencies for advanced EMT. So you would want to incorporate those into your curriculum. The NANR EMT practice analysis would not be a bad thing to review, to just understand what the practice analysis is the registry goes out and they try to find out what is actually being done by EMS professionals at the various levels so that their test can be based on practice. So while that shouldn't dictate our curriculum, it should definitely advise it. And then stakeholder interests at the private level, the local level. I think this is very important too. We need to look at how our local EMS agencies deliver care. Uh, that could guide some of your curricular decisions. Now, I want to be careful about this one. I'm not saying we teach directly to a specific agency's protocols, but you would want your curriculum to cover what your students are going to see when they go out into the field, and you may have to make some changes to that. Two examples in my program are we have started to cover Keppra or levetiracetam in our seizure section because one of our agencies is carrying this now. And so I'd like my graduates to be familiar with that. Plus, if they're going on transfers and somebody has a neurological issue, often they're receiving this as an infusion. Another issue that is coming up is nitrous. One of our local agencies is using that now. We hadn't covered it really very well before because no one had it. And when they started carrying it and they approached us about it, it showed a hole in our curriculum that we needed to fill. And so we're working on that now. We see a lot of EMS agencies in social media that are starting to carry and administer blood now. We should be covering that in the curriculum, especially if they're going to be going to agencies that are going to administer blood. And that's the thing we all know because we come from the field that we work in a dynamic profession and things are going to change. And so having control of the curriculum and getting feedback from our local agencies is going to be critical in making sure it stays current and relevant. Student needs can drive this too. Maybe you do a couple of cohorts of your program and you realize you're just not covering a certain subject enough. Maybe throughout the last 2 or 3 years, your groups have had a lot of trouble interpreting EKGs or doing dosage calculation or something like that. Then you maybe would want to adjust your curriculum, add training, think about maybe teaching something a little bit differently, something along those lines. So the students would help guide that. Medical direction obviously is very important. We're all partnered with our medical directors for clinical accuracy and making sure that all of the clinical content that we teach is current, up to date. Our medical directors usually are going to have a good grasp of the current issues that are being discussed in the field. So we could rely on them. I have lots of text conversations with my medical director about, okay, have you ever heard of doing this? Have you ever heard of doing that? How important do you think that would be? Excellent source of information. Our advisory committees are a good source also. If we've staffed them with people that can give us good feedback about what's going on in the field, that can really help. Other stakeholder interests and the employers. Now, the employers and advisory committees often tend to be the same people, but even if they're not, it's a good idea to find out what different agencies are doing in your area. Going backwards a little bit in the hierarchy would be state and regional. In Louisiana, we have a state scope of practice matrix that our bureau has put together. It's a really well done document that delineates what is within the scope of practice for each different provider level. And so obviously I'm a Louisiana based paramedic and advanced EMT program. So we're going to make sure that we cover everything that is in the state scope of practice and not only cover it, but we're trying to insert wherever possible when it's relevant to a particular subject. Here's what the state scope of practice actually says about this particular thing. And so there's been some debates about that. I know advanced EMT has had a lot of debates about what they're actually allowed to do, what they're not allowed to do. We see this with EMT too. Paramedic has had some issues, like we mentioned, blood administration. There's a lot of confusion about what we're allowed to do with that. In the past, we've not been allowed to start blood, but we could continue it. Whereas the scope of practice is changing as practice is changing, and so we would need to adjust our education to match that. Some areas have regional requirements. In my state, we don't have regional EMS offices or anything like that, but I know other states do. So you would obviously want to consider those as well. And then advances in EMS, just in general, our profession is changing. The medical side of it is changing all the time. We get new research, we learn new things, and we need to adapt those. It's tough when it comes to the new advances. Is you want to be current, but sometimes things come out and get very popular on social media before there's a really good evidence base to support them. And so I call that the bleeding edge. And you probably don't want to be on the bleeding edge, but you definitely don't want to lag too far behind. That's where involving your medical director and your employers and other people is a really great idea, because they'll have a good idea of what we're doing right now. They'll know what direction they want to go, and we can keep our curriculum relevant and without going too far. Because part of the problem with all of this you're having to consider is most of us have a reasonably fixed amount of time. And so adding things to the curriculum sometimes requires us to take things out, or it requires us to do a lot of work getting more time to be able to teach them. So we're having to decide how best to use the amount of time we have. Another thing that not scope practice, but the EMS education standards do is they spend a bit of time talking about depth and breadth, which is probably my favorite part of the document, because I think this concept of breadth and depth is very important. So breadth is the amount of things you're covering, and depth is how deep you're covering each of those things. And one of the reasons I like this concept is because we know from all the cognitive psychology research related to teaching and learning is that the deeper you process a concept, the easier it is to remember and the more available it is for you to use it when the time comes. And so sitting down and thinking about, okay, well, how broad am I covering? Enough topics, enough things, but also how deeply am I covering those topics? I know when I sit down and think about this, one of the things that always strikes me is I probably need to cover things a little bit deeper than I am. And so this goes to kind of figuring out what the end you want your curriculum to be, and where you want your graduates to be when they're done. And so I want do I want to base things just on strictly entry level competence, and I want to get them just to where they can cross the line on the registry and no further, or do we maybe need to go past that to actually function in the area that I'm teaching in? And that's my argument, is that if you base everything on just your conception of entry level competence, you're probably not going deep enough and in your program. But and there's no real way to measure this. Like, there's no scale. It's all conceptual. But just sitting with your faculty and your medical director and thinking about this on a concept by concept basis, how deep should we be taking this, so that the students can understand and they can function in our world when they graduate. But again, I strongly recommend you all read the EMS Education Standards. There's a lot of good stuff in there about the theory behind curriculum development. All right, so enough about that. The second thing is begin with the end in mind. Again, I stole this from Stephen R. Covey, but I think it's really relevant. This really is the end for us. Our goal is to prepare students that can respond to this dispatch and be able to deliver safe, effective care to this child or whoever the patient's going to be. And so I think we need to remember that. As I was saying before, I would not want to build my curriculum and guide how we conducted the program based on passing the registry exam. My argument is that if you prepare them for real life, if you prepare them to handle this call and the other calls they're going to run, the calls that we all know about, the registry will take care of itself. And so this is what I would recommend we focus on is what are our graduates going to do in the real world? And have we prepared them to handle that? And have we assessed them on that? And that's really where clinical judgment comes in. I mean, clinical judgment is involved in taking tests, but it's really involved in taking care of patients. So this is the clinical judgment model that the registry has given us. There's lots of different models out there for how people make decisions. Some of you may be familiar with the OODA loop from Colonel John Boyd, or the two-system model from Dr. Daniel Kahneman, Dr. Crosscarry. There's a lot of different ways that we've proposed how people make decisions. Well, this was developed by EMS professionals to explain how we make decisions. And I think it's really good. And it behooves all of us to understand this concept. This whole clinical judgment piece is kind of a meta curriculum that goes across the entire program. It's not just in one little place. I would not spend 2 hours talking about clinical judgment and then that's the end of it in your program. This needs to be something we revisit over and over and over again. And we'll talk more in depth about how the model works and everything. That's not really the focus of this talk, but the model kind of covers all the aspects of a response in EMS. And so we can think about, okay, well, here's the different pieces of how we would respond to this call. Have we given the students enough information to be able to recognize the cues, as it says in there, and analyze them? Because those are probably the two biggest things for us is, do they know enough to see things when they happen? And then are they able to process those things and then be able to make decisions about them? So I definitely would spend some time thinking about how this model and the concepts that it's teaching can be put into your entire curriculum across the board. One of the key things about clinical judgment is knowledge. So a large store of well-organized knowledge leads to better clinical judgment, which improves the accuracy of our field diagnosis. Now, this is my statement. I'm going to own it. But I think everything I've read about learning, about teaching, about clinical decision making, all the science that goes behind this, one of the key factors in being able to make quick decisions that are correct and being able to form a good diagnosis is knowledge. We've got to know a lot of stuff, and that's our job as educators, is to give them this knowledge. Part of curricular development is the well organized part. Not only do we just dump a ton of stuff on them, we do it in a way that they can absorb it, they can process it, and then we test them so that they have a chance to apply it. That's what helps the knowledge to be well organized and accessible to the students when it comes time to use their judgment to make sure they have an accurate field diagnosis. And so that teaching is basically, the basic model of teaching and learning. You start with encoding, where you present information and the students process it so that they can store it. It first goes through your working memory, then it goes into your long-term memory, and then long-term memory, the way we build that is to retrieve the information. So having to reuse the information over and over in different settings helps make it easier to retrieve. And then the more they do that in the program, the better off they are in the field when they have to retrieve information in real life. So we affect each piece of this process. The encoding is very important because we're going to be thoughtful about the way we present the information, the way we assess it, the way we teach it, all of that. And then we're going to help them store it better by the way we assess it and by the way we have them retrieve it. This cycle goes around and around and around. They understand a concept at a bare minimum level at the very beginning. And then when we revisit it later, when they've learned new things, they encode new information that attaches to the old information they've already had. And then it gets stored. And then eventually we retrieve it and we just repeat the process. So again, beginning with the end in mind, understand that this is what leads to that end. The end is being able to apply this information in the treatment of the patient. And this is what's happening in our brain as we're making decisions. This is from the clinical judgment model. We recognize a cue. We recognize something is there. And I think that's very important because there's that old quote that I don't know who actually said it, but I think it's very relevant. The eyes cannot see what the mind does not know. And so if we have not taught them enough about a particular subject, then they're not even going to recognize the cues and know to start this process. But they recognize a cue, a vital sign abnormality, an assessment finding, whatever it is. They analyze that cue to determine what they need to do with it, because just a piece of information by itself doesn't really dictate anything. We've got to understand why. It's like seeing VFib on the monitor when you're driving down a Louisiana road. Well, that may not be VFib, that may be artifact. And so understanding enough to analyze that, oh, well, I see a good pulse ox waveform, and we're probably okay. Or carbon monoxide and pulse oximeter. There's tons of examples of this. But analyzing the cue, making a judgment about what we think that cue means. So do I need to defibrillate my patient, or do I need to recite my electrodes? Do I need to just hold on for a minute until the road gets better? I've made a judgment about what I think is going on, which is going to lead to an action of generating the solutions, take the action, and then evaluate how that action affected the patient, and then continue the process. You may go through this loop 100 times on a call, depending on how complicated it is and how far away you are from the hospital. But again, the curriculum should prepare our students to do this. And I think the depth and breadth is very important when it comes to that, because do they understand the concepts deeply enough to be able to make these decisions? Do they understand enough breadth? Do they have enough concepts in their head to be able to recognize a cue when it happens? These are all, very important things. All right, the next phase is different kinds of knowledge. There's a whole field of knowledge management that's kind of geared towards companies and organizations, but I think it's very relevant to us because a lot of what really helps our students be able to actually apply things in the field, it's not just knowing a concept, being able to define a word or recite something. It's also knowing how that works in real life with the patient. Uh, and so it's kind of important to consider all that when we try to set our expectations for what our students should be able to do. So the first type of knowledge I think is pretty well known to all of us. You may not know the name, but it's what school is basically about. It's declarative knowledge. So kind of knowing things. Sometimes it's referred to as theoretical knowledge or descriptive knowledge or propositional knowledge. But the whole point is these are facts. These are things that are just pieces of information that we would need to know. That's mostly what people think about school, is communicating declarative knowledge. But because our discipline is also an applied discipline, there's other kinds of knowledge that are very important too. It's not enough just to learn a fact to pass a test. We've got to be able to use that information to do something. In our case, take care of a patient. So another kind of knowledge is procedural knowledge, knowing how. So that's very important to us. And that's not just for the lab. It's not just being able to perform a skill. Everything that we get in class, every piece of knowledge, every concept we learn, we need to know, how am I going to put this into practice in a patient scenario? And so I wouldn't, one of the things that I think is important is not to limit your discussion of procedural knowledge to just the lab, but put it into the lecture too. There's a thing called worked examples that are a great way to teach, where you teach a concept and then you demonstrate to the students how you would use that concept. So the obvious benefit to this is like dosage calculation or EKGs. You can do those in class. Here's how you measure the rate on an EKG. Let me show you how to do this a few times. Now let's do it together a few times and then have them do it a few times. So that's developing procedural knowledge. As you teach them the facts about how much time the boxes take up and all of that, and then you show them how to make it work, and then you have them make it work. So they're developing procedural knowledge. Sometimes this is known as practical knowledge or imperative knowledge or performative knowledge. But the idea is just knowing how to do whatever it is you're talking about. And that can change the way you teach it. The way I teach one subject may not be the same as the way I teach another subject, based on what kind of knowledge it is and how that knowledge is going to be applied. Another way to describe knowledge is explicit knowledge. So this is the stuff that most people know about. It's recorded, it's easily transmitted. We pass it from person to person. Your textbook is explicit knowledge. Your slides are explicit knowledge for the most part. These are things that are out in the open, they're obvious. But contrast that with tacit knowledge, which I think is another area that's very important to clinical judgment, because a lot of our ability to use clinical judgment well is not just about knowing things, but knowing how to apply those things and knowing some of the unwritten aspects of the various concepts. So tacit knowledge is things you learn by doing. So you perform a skill 100 times, you learn ways to perform that skill, you learn things to make the skill better that maybe aren't in the textbook or aren't explicitly said. And so that would be tacit knowledge. Often the stuff's not recorded. Sometimes it's not even recognized. You just develop tacit knowledge on your own, and it improves how you do your job, but you don't really understand why you're doing what you're doing. This is one of those differences between a novice and an expert. Is experts are better at doing things, and sometimes they can't always explain why they're better because of the tacit knowledge. And this knowledge can be difficult to communicate, but it's essential. I mean, every organization requires the use of tacit knowledge. And I would argue, to successfully pass an EMT or a paramedic program, you need to be developing tacit knowledge. So one of the things that I think is important for us is, wherever possible, let's identify the tacit knowledge that we assume the students should know, but they may not because they don't have our experience. And then try to incorporate that into the way we teach, have something tacit or implicit, try to make it more explicit to the students. And I know that's not always an easy task, but I think it's going to help. It's going to help understanding the material we're presenting, and then it will improve clinical judgment. Little things like how patients present, things you'll see, cues you'll get that may not always be in the textbook. Just sitting down and really thinking about, okay, I've had this particular call. What was involved in me doing a good job managing this call? And then asking yourself, have I taught that to my students? And you don't always have to teach it initially. Maybe some of the tacit knowledge comes later in the feedback. It's like, okay, they've run the call. They've done it pretty much like we taught them to do. Now that it's fresh on their mind and it's time to do a little bit of teaching. Okay, so here's how I found this works based on me doing the same thing. And that's a great time to impart some of that knowledge to them. All right, my last point is to use a taxonomy to guide writing your curriculum and your assessment. Taxonomies are basically just ways to structure things. And when it comes to education, we have taxonomies that help us understand how information, the complexity of information, the depth of information, that's really the function. One of the key things to understand, as I said before, is that deep processing leads to better understanding and easier retrieval of information. So if your goal really is for them to do well on your test and to do well on the national registry, if you push them to go past just entry level depth of the material, when it comes time for them to perform at an entry level, they're going to do better. The more time you spend thinking about something, the better you are able to remember it. And the deeper you process a concept, the better you're going to understand it, especially if you have to apply it at a level that's not quite as deep. And so taxonomies really help with that. They help make sure that our programs have adequate depth, and they help us push that a little bit further. So the classic example of a taxonomy in education is Bloom's taxonomy. Now, they've actually revised Bloom's taxonomy, and I think the revision is a lot better. And so at the very top is the most complex type of activity that you would do in an educational program. So one thing to remember about Bloom, and I would say the Marzano that I'm about to talk about also, is that these are not guides for difficulty so much. They're guides of complexity and depth. So if you're going to write test items based on Bloom, it's not, strictly speaking, the higher you go in the taxonomy, the more difficult the item is. You can have a remember level item that tests something very obscure that most people get wrong. But the higher you up go, it's more complex. I like the revised taxonomy because they put create at the top. And I think this is something we can implement in our programs. One of the things that I do is I have students write scenarios for the lab that they then run with their classmates. So if you think about how much they have to know to be able to write a scenario that they would put their classmates through, that's a lot of high level thinking. That's a lot of depth. And a part of the scenario template is they have to explain the pathophysiology and how you would assess them, why you would do the assessment. So obviously you wouldn't put a create type assignment on them at the very beginning, but at the very end, when you've taught them the material, this is a good way to assess how well they know it. It's a good way for them to think about it and process it. So I like that. Evaluate is a little bit less than that. So you're taking the concept and you're evaluating it, analyze, apply, understand, remember. We're not going to spend a ton of time on Bloom's because I want to introduce you to Marzano's taxonomy, which is a different way to look at these things. But like I say, Bloom's has been around a long time. There's a lot of resources on it. If you want to use Bloom's, there's nothing wrong with that. I prefer the revised taxonomy. You can always Google it and find all the different verbs that relate to the different areas so that you can write test items and objectives. But let's talk a little bit about Marzano. So Marzano has the top two levels here are like overall areas, and then the cognitive area are the last four. And so one of the things that we realized when we were preparing the clinical judgment workshop was that we spent a lot of time talking about metacognition, and we really didn't define metacognition. And Marzano does a good job of that. Metacognition, basically, in a nutshell, is thinking about thinking. Be aware of why you're making the decisions you are, the values you're placing on different information. And for clinical judgment, that really is key. That clinical judgment is not, it's not enough to just see something and do something. You've got to attach value to whatever it is you see, and then you've got to make decisions about what you're going to do with that information, which the wheel we talked about a minute ago, that's all about that. So a lot of that is metacognition. So let's start at the very low level and work our way up, or the very shallow level and work our way up. Again, I hate to put value judgments on this like low or high, because even the stuff we would consider lower level, just basic knowledge, is vital. If you don't have knowledge, you can't do the higher level stuff. So learning the facts and the concepts is vital so that you can push yourself to do the higher level thinking or the deeper processing. But retrieval in the Marzano framework, you've got recognize, recall, or execute. These are things that are you're still taking action, you're still doing something, but it's not requiring a ton of processing or very much depth to be able to do. Recognizing something you've seen before, a word or an EKG pattern or something like that, recalling a piece of information, executing a simple task. These are all retrieval level tasks, but obviously you can see they're very important. Comprehension is where you're starting to process a little bit deeper. You're integrating one concept with another. This is vital with our curriculum. You've got to be looking at information that's been presented before when you're thinking about how to teach a concept, and integrate as much as possible what they've already known or what already been taught into the new concept. The more we can link things together and integrate them, the better they're going to be able to remember them and apply them. Can they describe things? Can they describe relationships, things like that? Symbolizing. So can they draw something out or express it in a symbolic form? Analysis. This is where we really start to get into the judgment piece. Matching. So they can identify things that are similar and different. The different becomes a real thing too. Can they identify when something is an example of the concept we're talking about versus when something is not an example of the concept we're talking about? Classifying. So we do a lot of that in what we do. We have various classification schemes, and we're trying to decide which part the patient fits into. Analyzing errors. Maybe they're our own errors that we're analyzing after the fact. Maybe they're errors of somebody else. How often have you gone to a call and the dispatcher told you something that the call was nothing like? But the thing of it is, if you sit down and really think about it, you can see why the dispatcher said what they said. The example that I was just talking about in class the other day is syncope versus seizures versus sudden cardiac arrest. Most of the time when I get called to any one of those three, I'm dispatched to a seizure. That's been predominantly in my history. That's been predominantly what I was dispatched to. And then when I got there, I found something else entirely. Maybe there was a sudden cardiac arrest where they dropped and shook a little bit, or maybe they had syncope and dropped and shook a little bit. And so presenting your students with those kinds of opportunities to work their way through that kind of call, I think would be very beneficial. So they can do that deeper processing. Generalizing and specifying, inferring things from general knowledge, and then making predictions about what's going to happen based on the information they have. Again, this is great for assignments. It would also be good at the end of a scenario to guide your discussion about how the call went and what they should learn from it. So having questions already written out that cover these areas would be very helpful. Knowledge utilization. So investigating, we do a lot of that, just patient assessment. Every question they ask, every assessment procedure they perform, every diagnostic test, we're investigating. Then we're going to have to make judgments about what those facts mean so that we can use them to treat the patient. And experimenting, I think, is another one. We really don't like using the word experimenting when it comes to patients. But if you remember back to the model, it talks about a hypothesis. Whenever you come to a conclusion about what's going on based on what you've done, that's a hypothesis. That's what a field diagnosis is this is our hypothesis about what's going on. And then that becomes our guiding principle for how we act. And then we reevaluate. So the experimentation is, okay, this is what I thought was going on based on everything I found so far. I've taken certain steps, or we've taken some time, and now the patient has had time to have their disease come up a little bit better. Okay, well, is my hypothesis still good, or do I need to revise it? That's an experiment. That's not really experimenting on a patient like we would think. It's just, this is the way we think. This is the way we make judgments. And then our thinking evolves as the call evolves. And so when you're writing scenarios, think about that. What changes can we have in the patient that real patients would actually make that would make the students revisit? If they come to the correct answer too quickly, then they don't have to revise their hypothesis. They don't have to revise their diagnosis. That's not real life. It makes it easier in the lab, but that's not preparing them for real life. So the way to do it is to scaffold them, have some pretty easy calls to begin with in the lab, some pretty easy scenarios that are fairly straightforward, and then increase the depth and increase the level of processing required to run that call, and use this as a guide for how to do that. That's one of the reasons that taxonomies are great. We're not having to start from scratch. We have somebody that's already done a lot of that thinking for us, and we just have to apply it. Problem solving, again, we do this all day long in EMS. Everybody else on campus is talking about critical thinking. Well, it's built into our entire program, and it has been from the beginning. Decision making, same thing. It's not enough to solve the problem. You got to decide. You got to do something that will lead to action, because ultimately that's what we need to do, is we need to act to help our patients. And then, so that was the cognitive area. Now let's talk about metacognition a little bit. So specifying goals. So you're thinking about what I want to know. So a particular one for us is going to be maybe discussing with the students, okay, so you did this during this scenario or on this test or assignment. What do you think you need to do to get better? A discussion of study skills might be in order here. Okay, so your goal is to become a paramedic. Right now, your performance is not going to lead to that goal. What can you do to change that? So that they have to think about how they're studying, how they're thinking about the material, all of that, and then specify some goals. Process monitoring leads to that also. So if they're studying a certain way, or maybe their patient assessment process goes kind of a certain way, but it's not doesn't lead to the best assessment, we need to get them to understand that so they can adjust it. And then hopefully what happens by the end of the program is they're doing these things on their own without us prompting them. That's really how we know we've succeeded in creating a good quality EMS professional, is they can self-correct. Not that feedback's ever a bad thing, but they need to be doing this a lot on their own too, and that's metacognition. Monitoring clarity, how well they understand things. If they're not able to process a concept, they need to be able to tell us that. Monitoring accuracy is another one too. We ask them to make a lot of judgments. We ask them to make a lot of decisions. And are they thinking about whether those decisions were accurate or not? Are they thinking about whether they've come to the correct one or not? And then if it's not correct, what do they need to do to come to the correct decision the next time? And then the last is self-system thinking. So examining importance of things, attaching value to things. We do that with every assessment we use in EMS. And every piece of information we gather. We all know this, that you get thrown a ton of different things on a call. Well, am I able to pick and choose what's important and what's not? And then if I'm not doing a good job at that, how can I improve that? Examining efficacy. Can you examine how much you believe that you can improve their understanding of a specific knowledge? To me, this one's a big one. We talk a lot about self-esteem in education, which is not necessarily a bad thing, but efficacy is so much more important. The students need to believe that they can do this. Carol Dweck's work about mindset speaks a lot about this. Do you have a growth mindset or a fixed mindset? But we need to get the students to understand they can do this and guide them into realizing that on their own. We're never going to be able to impose it on them, but if we can help them get to the point where they do realize that they can do a certain thing, then hopefully after time they'll be able to repeat that process on their own, and then that's going to affect their learning. If they believe they can do something, if they've seen evidence they can do something, then their performance is going to improve. Examining the emotional response, you can't separate any of this from emotion, fear, anger. There's all kinds of emotions that play a role. And so to not discuss those and to not bring those to the student's attention would not be completely teaching them what we need them to know. Because part of what we're doing is we are managing our emotions to be able to think clearly. If we allow our emotions to get the better of us, we're not thinking clearly anymore, and our clinical judgment will suffer. And then motivation is another one, why they're doing what they're doing. It's kind of interesting with this one. You'd think that we would not need to examine motivation as much as we do, but we still have to motivate our students. They don't come to us completely pre-motivated and ready to go, even though they have a really good idea of what they're getting into and they've seen it in the field for the most part, and they've seen people doing this job for the most part. Sometimes we still have to evaluate what's motivating them and get them to evaluate what's motivating them so that they can improve. Sometimes that motivation is a hindrance if we don't address it. And so, but this affects everything we do. And so that's why these are at the top of Marzano and Kendall's taxonomy, is because they affect everything. So that's pretty much my spiel. My time says I'm just about up. So like I said, we need to own the curriculum, because we do. Begin with the end in mind. Think about what the students are going to need to do at the end, and then work your way backwards. Think about the different kinds of knowledge that are involved in what we do, and making sure that we incorporate those types of knowledge into our curriculum wherever possible. And then use a taxonomy to guide your writing of your curriculum and your assessments. And I think now is the time for questions or criticism. Welcome to that too. Like most EMS people, I'm very uncomfortable with silence.
I'm sorry, Jeff. I was just waiting to see if anybody else was going to ask any questions here. But it is uncomfortable, I'll admit that. Um, I guess if Oh, there, we do have one question from Brian. Brian asks, how much of the taxonomy do you think makes up your syllabus?
So we are the curriculum that we're currently operating under. We wrote using Bloom's revised taxonomy just to give us a guide for the verbs we used for our objectives and stuff. We're in the process of revisiting that, but the way we did it, and I think it's the right way to do it. Other people could tell better because they have more letters behind their name. But just like when you're writing a test question, when you're writing an objective that you're going to put in your syllabus, you would use the verbs in the taxonomy. And so what we tried to do was use some of the simpler concepts in the taxonomy first, and use those verbs to write some foundational objectives. And then the idea was to get deeper and deeper with the processing as we went. And as with anything, the version that we have now, I realize now 5 years later that there's a lot of holes that we need to fix. And so we're in the process of redoing that, but I'll be using Marzano this time. Again, I'm not saying that Marzano is definitely better. For me, it makes more sense, but we will be using the verbs and the concepts to try to map out our curriculum. Because one of the things you want to do with your objectives is you want to go from simple to complex, or, shallow to deep, however you want to look at it. And that, again, that's where I think the taxonomy really helps, is it helps us get to where we're coming deeper. Because I know when it comes to writing test questions, one of the things that I find is, and objectives I think fall in the same category, I think I'm writing something that's at a deeper level, but the reality is I've reverted back to something that's shallower or simpler. And so having an external source to guide the conversation with my faculty and me about that helps push us to making things deeper. I hope that answered your question.
All right. Not a question, but Jacqueline says, thank you. I always enjoy the trip back from the hospital where we can discuss our call and evaluate. We then discuss what we can do better.
Oh yeah, that's the best time to give feedback when something's fresh. I don't tend to have a lot. I work in the field still, but I don't tend to have a lot of students where I work. But the same thing could be said in the lab when you're running a scenario. You put them through something, especially the harder scenarios. We have some in our program we call Kobayashi Maru scenarios, Star Trek reference, where most people don't get these right. But that's okay, because the whole point of me putting them through that is not to humiliate them, is to provide an opportunity for them to learn. And so sometimes epic failure is a really good way to teach somebody. And I'd rather do that in the lab, obviously. But yeah, those conversations when they're primed to have them are really golden.
Brian also asks, do you think that their ride time is a good indicator of the success of the teaching methods?
I do. Now, obviously, just like with clinical judgment, educator judgment, we have to take the information and process it and make our own value judgments. But I think rideouts are a good indicator. You can always tell by the feedback, or usually you can tell by the feedback, um, what issues the preceptors are having if they give you the feedback. Um, so yeah, I definitely, and I know for us, we've had to revisit things because the preceptors are like, look, they just can't read a 12 lead or something like that. And so I may think I taught 12 lead amazingly because I'm an amazing teacher. But if they can't do it in the field with the preceptor, then guess what? I'm not as amazing as I thought I was, and it's time to revisit. Very hard pill to swallow for me, anyway.
All right. I don't see any other questions. So, Jeff, is there anything else you wanted to say?
I really hope you guys get to come to one of the workshops. I think they're excellent. There's a team of people that are going to be teaching you. I am the very junior member of the team, so the people that you're going to spend the most time with are amazing. And I hope you get to come, and I hope I get to meet y'all at these workshops. But thank you for your time.
Perfect. Thank you so much, Jeff. Everybody, I did put the registration for those workshops in the chat. You have the option to come to Hearst, Texas or Oaklawn, Illinois, and they are completely free to attend. It is an all-day experience on a Friday. Highly recommend joining one of those. And I also put the link to the CEU for today's webinar in the chat as well. And I will also make sure that all of this information goes out in tomorrow's follow-up email. And I think with that, we will wrap it up. So again, thank you so much, Jeff, for being here with us today and for being a part of this workshop. You are just a fantastic resource for NEMSI, and we truly appreciate it. So
Thank you.
thank you, and we will see everybody next time. Have a great day, everyone. Thank you.